the response of the whole world in COVID was stupid, was correct. Some countries did well, other countries didn't have any measures. I want your thoughts.
You're trying to get me fired from public health. No, actually...
I'm here with Andrie Panayiotou, and we're going to talk about epidemiology, pandemics meaning, and public health. What is pandemics?
Okay, so we're starting off immediately with pandemics. A pandemic is any disease that introduces excess mortality or morbidity in a population. It's a disease that doesn't exist within the community, but is coming from outside.
Where outside?
From outside the community. So for example, COVID, because I'm sure you had COVID in mind when you asked that question.
And everyone else in the audience as well.
Yes. Well, that specific disease did not exist before or did not have a big burden on communities and countries and populations. And it came and brought mortality and morbidity with it. It's called a pandemic instead of an epidemic because it affects a lot of countries. So if it only had affected one country or two countries or regions, it would have been an epidemic.
So malaria is an epidemic.
Malaria is endemic in some populations and epidemic in some others.
What does that mean?
Okay, I need to clarify a lot of things. Okay, so actually Hippocrates was the first one to say the word epidemic 2,000 years ago. And it comes from the words epi and demos. And it's anything that visits the community.
Okay.
Endemic, en και demos, is anything that exists in the community. So a disease that exists in the community is endemic. In some countries in Africa, malaria is endemic because it exists in the community.
It exists, but sometime it came, or it exists because of the dirty mosquitoes, so it exists. Or maybe it's not because of the dirty mosquitoes, maybe that's the way that it transferred. So,
yes. If you remember, we for the COVID pandemic, we're discussing when and if the pandemic would become endemic. Because at one time point, there will come a time where we will live with COVID.
So now it's endemic? It's not a pandemic?
Well, the pandemic was ended officially, if I'm not mistaken, last week.
Yes.
By the WHO. It hasn't officially become endemic everywhere, but it will become endemic. So we will be living with COVID every year, like the flu. Every year we will have a few cases of COVID, but it's something that we'll have every year. So it's something that we kind of live with in the community.
So malaria was at some point a pandemic and it became an endemic.
It was at some point an epidemic that came from
epidemic
outside.
Because it affected more than one country. No, some countries.
Yes, I don't think malaria was ever a pandemic because when malaria was introduced in communities, we didn't have the lifestyle we have today. With you will be in China tomorrow,
yes,
right? So anything you carry with you will be in China tomorrow. We didn't have that.
That's
fast.
interesting. That's interesting.
And that's how COVID spread so quickly and became a pandemic because there were a lot of
pandemics is a recent age. It's a recent thing. It didn't happen like probably because of planes and transportation and like 200-300 years ago. It's introduced in the world.
There were historical cases of pandemics, like the Black Flu, because it influenced both Europe and, or typhus, it influenced both Europe and the United States.
So it was at the time that we had transportation.
There always was transportation, but at that time it took a month and you had to cross by ship. Now it takes days.
So it was more difficult still, more friction. But what do you think we learned as a society from the whole pandemic of COVID? Now I will say correct terms. Pandemic of COVID.
I think the main message would be that we need to be prepared, because we knew that something like that had happened. There were issues of outbreaks of similar diseases in the past, but they were contained. They never became an epidemic or a pandemic. But because the bird flu, the swine flu in the 2010, there were other issues. They just didn't grow out to be pandemics. So as humans, we tend to have a very short-term memory. And we tend to forget what happened and forget that we need to be prepared when the next one comes.
And what does that mean in actual life? Like for me to have always a mask with me, or what does that mean? Prepared as a society,
Exactly.
as individuals, what does that mean?
As a society and as health systems. So it doesn't apply to you, although I would definitely recommend a mask in the plane. But it means that as countries, as health systems, as societies, we need to have enough resources to be able to pick up incidents, outbreaks as they happen, and be able to address them. So, for example, it would mean better surveillance systems.
What surveillance system means?
It's monitoring. It's when you keep a track of things.
Okay, so you know immediately when
Exactly.
stuff are happening.
You
so
know
you
that
don't
there are...
so you can limit and cut the entry of people in the country or something like that. So you...
Yeah, so you can apply measures. So if you know that there are more cases than you would expect of, let's say, bird flu, you take measures early on so it doesn't spread globally, for example.
And okay, monitoring. What other things can we do as? So we have, like, you recommend, like, for us to have as or a global or a national system that can monitor where the diseases, what are the threats, and all this stuff all the time. And
the world we live in is global, so the surveillance has to be global. And there are systems in place. It's just that when you have long periods of time where nothing happens, you cut the funding from those things and you take it to things that are more urgently in your face, sort of.
Interesting.
And one of the, what we always discuss with students is that public health, when everything goes well, nobody realizes it. Yes. So when you're doing a very good job on public health, everyone is happy. Nobody realizes it.
Not they're happy, but they're ignoring.
Happy, but yes. And it's easier to cut funding for things that you don't palpably see that they're working.
But then you need to have in mind that every 20 years, every 30 years, every 50 years, this will come and will big time damage you. So it's not a clever idea to cut the funding of it. So you think this happened actually? Like the funding was cut from all this stuff, or we didn't even think that this is a big threat to humanity? And
there were simulation models that showed evidence that there will be outbreaks in the next years. Especially in the US, there was a lot of funding cuts to surveillance systems and crisis response systems. And that also showed when the pandemic hit and they didn't have the people in place and the resources in place to deal with it effectively.
Now, after the pandemic, do you have a global something that all the countries agreed to?
There is a WHO that most countries report data to.
It's a problem when most countries and not all of them, because we are living in a global world. And
that's true. The CDC, both the European CDC and the American CDC, Center for Disease Control, they have surveillance systems. And European nations, European community has surveillance systems. And actually, I'd like to make a comment that African countries, because they have more infectious diseases on average than, let's say, more westernized countries, had better surveillance systems in place. And they actually did a very good work catching the cases early on. Because it was something they had on an ongoing basis because of other diseases.
Because they were trained.
Exactly.
Oh, so this is publicly known that Africa...
There is data that they had in many situations a better response.
Wow, that's cool. Africa for the weed for sometimes. It's cool. So what other things can we do in the future? Like to have funding for this thing, but is there any other things? Like, for example, one thing is talking about these problems, is like awareness, or teaching it in universities, or like what are the other, because this might come in the future. But by the way, I want you to comment later on how you think the global world responded to this, and like how, if you think stupid response and all this stuff. But first of all, what are other things? Let's close this. What are other things that can be done for this in the future to be prevent?
Well, all countries need to have public health agencies that keep a track of health indicators, and not just infectious diseases. Because we're talking about COVID, we're talking about infectious diseases, but health isn't affected only by infectious diseases. The majority of death and disease globally comes from non-communicable diseases. So meaning diseases that do not have an infectious agent. So heart disease, cancer, dementia, mental health, all of those are what we used to call chronic diseases, but that is no longer considered an appropriate term, because you could live with HIV, for example, for many, many years. So AIDS is now chronic disease by that definition. So non-communicable diseases are anything that doesn't have an infection as its cause. So
you cannot say it's a pandemic.
It hasn't been announced as that, but there is an epidemic of chronic diseases and chronic disease risk factors. I said chronic again, non-communicable diseases. So we are faced with epidemic of diabetes, of obesity, of healthy diets.
And these are, you're saying that we don't pay enough attention to those things. We think COVID is the big threat, and there is other stuff that are equally...
Well, for a period of time, COVID was the big thing. But the rest were there long before that and will be there long after that.
Interesting.
So that's something that we, again, need to pay attention to. And we are paying attention to. But it's something we're working on and we need to work on.
I have so many questions, but let's try to address the response of the whole world in COVID was stupid, was correct, was some countries did well, other countries didn't have any measures. I want your thoughts.
You're trying to get me fired from public health. No, actually, I think we did the best we could with the information we had.
So political correct answer.
And again, when you're saying how we did, depends on what you think is the best outcome. So if you take deaths, for example, and you say that we did very well if we had fewer deaths than expected, okay, then a lot of countries, including Cyprus, did very well. Okay, but if you think
Cyprus, by the way, is the country that we are now.
Yes.
A small island that not a lot of people know except around the island.
But there are other indicators. So if you think about financial loss or mental health, especially for children and adolescents, it depends where you put your metrics or your health. I mean, most countries decided that the cornerstone is human life. So human life is more valuable than anything else. We will strive to save as many human lives as possible. And if that means that people need to
suffer
stay at
with
home,
mental health,
No.
Let them suffer.
If that means that some jobs will be lost or there will be a financial burden to the government, then that's okay, because life is
Or
the
mental
ultimate.
health at any expense of for the goal.
We all agree that life is the ultimate value.
We all agree.
Yeah, I think we did.
Okay.
But at the same time, while you're trying to save as many lives as possible, it doesn't mean that you forget about everything else. And we didn't. I mean, I think what
That's a philosophical question, actually. If life is the ultimate, should you save one life in expense of 1,000 people being in prison? It's like, where do you draw the line on that? That's a philosophical, interesting question.
that is based on utilitarian ethics, which we can discuss later if you want to. I'm very happy to discuss. And a lot of public health decisions are based on utilitarian ethics, which means what is best for the majority of people. Then that is the right thing to do.
Okay. What is best for the majority of people?
So if
But
I can,
how do you measure that is very interesting, because our perception of what is best is very different to what actually might be true, because we might not be as clever.
no.
to add.
It's a very difficult question. It's a very difficult answer. So your question is actually very good, because if you say that life is the what we judge things on, if I can save 100 people's lives by killing one, should I do it?
I will do it.
You would do it.
Kill that motherfucker.
But what about the value of that person's life? Because if you have agreed that life, human life anyway, is most valuable, and we're going to base our policy so that not even a single life is lost when it shouldn't, then you shouldn't kill that one.
When it shouldn't.
But what about the other 100?
Yeah. Difficult stuff.
Well, that's why in ethics, and I'm sidetracking, we're talking about dilemmas.
There is no sidetracking. It's all about the experience of life.
So we're not talking about problems. We're talking about dilemmas, because problems have a solution. You can find it, right? But ethical dilemmas don't have a solution. So you just need to decide
what are your morals?
What are your morals? What are your morals as a society? And decide that whatever we do will be accepted by at least the majority of the population. And to segue back to COVID, because we decided that as a society, we place more value to human life than money, for example, we decided that we would endure lockdowns, we would endure all the other measures. Of course, money is important for health. So if we don't have money in the next 10 years, we'll need to cut down on things. And hopefully what we cut down money on is not health.
Interesting. So speaking about money, one question that I love to ask people is, I give you $1 trillion now. So what do you do with it? How you help the health system? What do you do? Or maybe you're not going to help the health system. You're going to give it to students to do research. Like how do you allocate that $1 trillion that you now have?
I'm not very good with deciding, but I think I would.
You need to be forced to decide. Before I came, she was like, "Thank God that you came, because I was forced to clean my office."
Yes. But since I'm forced to decide, I would probably not spend it all in one place. Let's say that. Trillion. Okay. It's not as much as it sounds. It's not as much money as it sounds when you think global scale.
Okay, interesting.
I think I would split among different things. Definitely research. Especially one piece would be basic research, because it tends to be not as well funded as applied research. But on the other hand,
And explain the difference between the two.
basic research is research that you do for the fun of it, not for the fun of it, for knowledge, so that you learn how
For the
things
fun of
work,
it.
so that you learn how things work and what could happen. Applied is you have something specific in mind and you want to turn it into an application, a product, something that does something very specific.
Okay.
Which is also needed, but unless you start with basic research, the ideas that feed into applied will never happen.
Yes.
That sounds like a very academic answer. What else?
So
Fund
you
public
give
health.
500 billion to basic and what's the other term? Applied research, and maybe a bit more to basic. How of the visibility between the two? And you give that like, I want a bit more detailed answer, like you here is university, do it. Oh, this is online thing that students sign up to do their basic research. Oh, I give it to the best researchers. Like how, let's go down to earth and like we have the money.
I think, ethically speaking as well, I would...
Ethically speaking, now.
I think I would have to go to countries and institutions that don't have the same resources for funding. So if I go and give it to MIT, they already have funding.
Yes.
But if I go and give it to researchers in
Kenya,
that will make a bigger difference for them. So $1 million
for
in
them,
Kenya...
For them, and the question is for the whole world, because maybe they have different understanding and different thing, and will come up with different, because they have naturally different experience of life than the US people. They will maybe have different innovation.
Exactly.
And stuff.
Exactly. And I found out in my research life that people who've learned to do research with limited resources are more innovative. They think outside the box and they figure out ways to do what they want to do with less money. And the fact that you exactly what you said, they bring different experiences and different ways of thinking. So we could be missing out globally on the potential of a big part of the world because they don't have the same opportunities.
So you go and make a research lab in Kenya and employ people and tell them, have fun, explore ideas and all this stuff.
Yeah, maybe.
Okay. What about you said about 500 billion that...
I did.
Those two. You said I will split the half.
I said half.
You can change.
I can change.
We didn't make a contract yet.
Okay. I think, again, I would focus more on trying to alleviate inequities. And let me explain the difference between inequity and inequality. So,
okay, interesting.
So equality is, I take a researcher, for example, from MIT and a researcher from the University of Kenya, and I give them both $1 million and say, do whatever you want with it, right?
Despite that the $1 million for the US person is good, and the person from Kenya is like the fortune of a lifetime.
I gave them both $1 million, right? I gave them equal money. But if the person from MIT, for example, already has access to multi-million-dollar funding, it might not make a big difference for him, right? But to the person from Kenya, it might make a much bigger difference. If I offered 500,000 to the one from the US and $1.5 million to the other from Kenya, that might bring them to the same level of infrastructure or resources. So inequity is when equity is when you give each person what they need so that they both reach the same level.
Interesting. It's like you have a child and the one child is like very clever and he has a lot of money and he has a great job, and the other child is like he's not clever, but he's more an artist or something. So you die when you split the money when you die or something. you give more money to the other child. You direct the money in kind of
When you put it in a family, it becomes a little bit less, more difficult to see the point of it. But yes, it's giving people
Yes,
what they need
I
and not
agree
what they
with
want.
you. It's more the example that you gave is a lot more vivid to.
Because I was thinking my children will probably hate me if I split things unequally amongst them. But yeah, that's the concept. And if there's any money left over, I don't know, inequities that come from...
Buy a yacht.
Buy a yacht, yes. A beach house.
A beach house. Here in Limassol or in Kenya.
Or somewhere cheaper than Limassol.
Cheaper than Limassol. But you have $1 trillion. So
True.
Limassol is pretty cheap for $1 trillion.
True.
Okay, so you touched on more diseases that we suffer as a society. And I want you to elaborate how big you think that's of a problem of society and how we go about addressing it.
Well, we know that non-communicable diseases, mainly heart diseases, which include stroke and heart attacks for their majority, and cancers, all types of cancers, account for more than 70% of death and disease globally. So we know it's a big problem.
Oh, interesting. But there is so many diseases in that bracket.
The top 10 or the top 5 causes of death and disease include strokes, heart attacks, cancers, Alzheimer's is coming up in high...
And you are saying of deaths now.
Of death and disease, living with disease. And so as a global society, we face more death and disease from these causes than from communicable diseases,
Which
on average. Which are HIV, malaria,
okay.
Or malnutrition.
So you are saying we need to allocate our resources equally to the problems that we are facing.
We actually are. I mean, the European Union has a cancer plan for the next 5 or 10 years, where it's allocating more funding to cancer research and non-communicable disease research. So we are aware of it. We are trying to deal with it. But the problem is that behind those diseases, there's a host of risk factors that are both genetic, so not much you can do about, but also behavioral.
It depends. Now I have some stuff to do with CRISPR and all this stuff.
To sidetrack again, not for CRISPR modifies single genes. So it works, or it will work, for single gene diseases. So if you have a disease that is because of a single gene, then you can work on CRISPR-Cas9 for that. So I'll give you an example. It's based on our work. Hereditary hypercholesterolemia. Okay, it's when you're born with high levels of LDL, the bad cholesterol. Okay, and you're born with it. It's because of a gene, of a mutation, a change in a single gene.
I think I have that as well.
We'll discuss it more afterwards. And it's hereditary. It runs in families, right? So because it's a single gene that is responsible for it and a mutation, you can use the CRISPR-9 techniques and develop a genetic treatment that targets that single gene. But that is for a group of people. The majority of NCDs, and I'll talk about heart disease more because that's my area, is not because of a single gene. It's because of a lot of changes in a lot of genes, each adding a little bit. And it's the interaction of that makes up your genetic predisposition to heart disease. And that cannot be changed by CRISPR-9, unfortunately.
So you're saying it's more chaotic. It's like you don't know exactly what caused it. It's like multiples of factors. Maybe some of your genes that you have with your family, maybe some bad choices that you made in your life, radio energy, or exposed too much in bad food, or all this stuff. So, wow.
Which is why we call these diseases complex diseases. because they have complicated, because they have a multitude of reasons, of risk factors behind them. And they each interact with each other, and they all interact with your environment and the choices you make and where you live and how you behave. And that gives you your risk for disease, for outcome. So those diseases are complex. So CRISPR-Cas9 or genetic treatments can work for single gene diseases, but not for the majority of NCDs that are complex.
Which the more complex one, is there a correlation between more complex one equals more dangerous or no?
No. Actually, the more genes are involved to it, the less risk each one confers. And that has to do with evolutionary genetics. So if you had a mutation in you, a change in your gene, which was so bad, it increases your risk for, let's say, a heart attack by the time you were 40, you would have less children. Well, by the time you're 40, or earlier on in life.
What do you mean I will have less children?
If you were born with a mutation that increased your risk of dying at an early age, you would have less probability of getting married and having children.
Okay.
Right?
Yes.
So that mutation would have to pass on through your children. If you didn't have many children, or at all, it wouldn't...
The same with COVID, you're saying now. Like in the beginning, it was a bit more death rate, but as it went to more people, it became a bit lighter on the effect, on the people. I'm wrong.
Nah. No, you're not.
Because
not
it becomes less weak to be able to spread more, to maximize the...
It doesn't apply one-on-one on viruses because their mutations all mutations are random. So it's not like the virus thought, I need to change to be less harmful to humans so I can propagate. But out of all the mutations that happened, the one that randomly caused less death is the one that spread out more.
Yes, but this is what humans are doing as well.
That's how genetic evolution works.
Yeah.
Exactly.
Okay, so so you are saying that, but why? I don't understand why when you have a single thing that CRISPR can affect is a bit more dangerous than the complex one. I don't really understood you said that is less.
Diseases that have a single gene cause are usually more severe than diseases that have a lot of genes implicated behind them. Because for one gene to cause a disease, it means it has a big effect, right? So you only change one thing and it leads to disease. So it means it's a big change. Maybe it stops the protein from being produced at all. But if you have not small changes, less severe changes in several genes, each one of them doesn't really cause disease, right? But if you put all of them together, plus the environment, plus your choices, they increase your risk by a little bit. So I'll give you an example. I probably have a genetic predisposition for diabetes because I know it runs in my family. Okay, it's not a huge predisposition because the people who had it usually had excess body fat weight, or they didn't eat very well, or had other issues. So I know I have a genetic predisposition, but I will not 100% develop diabetes. I need to also do other things. Okay. Like gain weight, not exercise, not eating well.
So, but if you had the other one, it was going to be easier to be developed because it can thrive by itself without any other factors.
It would be a bigger change.
Got it. I'm curious to hear your thoughts on how do you see the future of health, the future of medicine and all this stuff, because we're approaching in an artificial intelligence era that maybe you can say to AI, help me find the solution for cancer, and we'll say, do this research, do this. Like, how do you see? I'm not limiting you to think that way, but like, how do you see the broader future of of health? You see, optimistic, pessimistic, why?
Again, that's a difficult question. I think I would say I'm optimistic, but there's a big but. So I would say that AI offers a lot of possibilities. It opens up many new worlds, and I only wish we could ask it what the cure for cancer was, and it would find it. But it's based on the data that we feed it. So we need to be aware of at least what goes in, because AI, we don't really know the process by which it comes to the answer. So the data that goes in. And also we need to early on start thinking and discussing as a society where we want it to go and how we want it to happen. Because going back to genetics as well, in the 20 years ago, there was a big burst in technology where we sequenced the entire human genome and we could get information on anyone's whole genome. Okay, we could do that technically, but we didn't have the time as a society to sit down and discuss, okay, we have that information. What are we going to do with it? Do we have a way to use it? Do we have a way to use it so that it has benefit? And it took us more than 10 years to discuss the ethical dilemmas behind it, or to feel more comfortable with it as a society. And I think we're a little bit in the same place here, where the technology is moving on so fast, and we haven't necessarily had the time to stop and discuss and think about where we want it to go and what we want to do with it. But I would say we're in a better place because we now have that experience, and we can earlier on see that we need to do that. And I think that's why a lot of people have asked for AI, not improvements, to stop, to pause for a minute so that we can think about it and discuss it. So I'm optimistic, but we need
but
to...
pessimistic about AI.
No, I'm optimistic that it will help a lot, and it has many applications for health. But we also need to be critical about it. Can I offer another example?
Yes.
Okay, so you probably don't remember this, but I'm old enough to remember that when I had a question, I had to open up an encyclopedia. I had to go look alphabetically and hope that my answer was...
No, I don't remember this. I never lived this.
There you go. But I remember that. And when the internet happened and Wikipedia happened, it became so much more easy. And you no longer needed to have the skill of searching an encyclopedia because it was on your fingertips. But we had to replace that skill with the skill of critically filtering the vast information that came from the internet, so that we could decide what was the right answer. In an encyclopedia, you believed it because it was curated. So we had to shift from one skill to another skill. And I think we're faced now again with a paradigm change. So I'm okay, for example, if my students use AI in an essay, but they have to first tell me about it. And I need the discussion and the conclusions to be their own. So I don't care if they get the information from AI, because that's information, you can get it. I need them to be able to critically assess, do I believe it? How do I synthesize the data? And what do I decide on that? And that's a skill that we need to develop now to replace the skill of writing the essay.
But there is more than to discuss about. This is such a deep topic because now what our doctors are doing, well, they're just doing what assessment on what the patient has, and this is what they're trying to give him treatment. But what if we have a watch that all the time gets data of us and knows us even better and knows our history and how our family tree and all this stuff, all the diseases that they have. It can and knows us 24/7. Also, not only knows us, but it knows 8 billion other people's and cross-correct data. Then you have are doctors useless immediately after 2 years? I think so, but like it will distract the whole health economy and the health system big time, I think, soon. So what do you think about this stuff?
I think I would disagree with you. I think that AI, again, is a tool. So instead of a doctor trying to collect all the data that you said, she can have the AI diagnosis, for example, and then check whether or not they agree on it. So I think the medical profession will become more of a critical. We'll have to decide how they're using that information. It's not that it will replace doctors, because even though we've developed AIs that are so sophisticated and so complicated, I don't think we're still where the human mind is. And what a medical professional or anyone does is get the information and decide what is the most likely thing that is happening to you. Could be 2 or 3. AI can, again, make the probability, but it will be based on the data. If the data is good, the prediction will be good, and the doctor will agree.
So we don't need a doctor. If the data are good, then the prediction is
How
good.
do you know the data is good? I don't think we're there yet.
Yes,
we
we're
can
not there
completely trust
yet
an
with the
AI.
data. Yes, I agree with that. But like when we are there, when the AI has the right data, we'll probably have better assessment of the doctor.
You might have better use of the time that doctors have.
You probably have a lot of friends that are doctors.
No, actually.
You don't.
No, but I think that human intuition is still not there for AI, and I could be wrong. I mean, it's not my area of expertise. Maybe we are there. Maybe there is an AI somewhere that has empathy and intuition and
Consciousness.
I don't know. I'll have to ask my colleagues. But I think that we still need the human perspective on it.
Can I ask you, like, what really a healthcare system means? You are in the healthcare system that you are teaching at university. Like, are you a part of the healthcare system because the government is funding some research? Like, what is? I want to picture and understand what it really is for me to meet with, not to meet with, to understand. So, what exactly is?
Okay, so a healthcare system or provider is anyone who provides care. So hospitals would be in the system, OKP for Cyprus, the insurance, the medical insurance organizations would be there, nurses, paramedics, anyone who provides care. Public health.
And it's public. It's not the private.
Not necessarily, all of them, private and public, whatever the situation is.
They provide.
Healthcare provision is under public health. It's more of a service. So you're providing healthcare, right? And that could be at any point at a person's life, from birth to death, for diseases or just maintaining their health. Public health is a bigger umbrella that includes healthcare, but is not limited to healthcare. So I probably wouldn't think of me as a healthcare provider, but I am in public health. And in public health, you would have also epidemiologists, statisticians, psychologists, social anthropologists, whatever, anyone who can work towards improving the population's health at all levels.
Do you know how much of GDP goes to public GDP goes to healthcare in the country that we are, and generally maybe in different countries and stuff?
Not by heart, but I do. They're measured separately. So there is a budget for healthcare, which would be in the national health system, for example, in the US or in the UK or in Cyprus. And there is another budget that goes to public health, and that has to do more with data collection, and public health policies. So things that apply at the bigger level. So for example, offering screening for breast cancer in the population, that's under public health. Treating cancer is healthcare. And I can tell you that there's a very small percentage, less than 1%, if I'm not mistaken, of GDP that goes towards public health. Mm-hmm. There's a much bigger part that goes towards healthcare.
Okay.
Because like I said, when public health works, you don't see it.
Yes. So, but it doesn't include the university inside that teach students how to do medicine. Or does research for cancer research and stuff?
Well, my colleagues at the medical schools do healthcare as well. So it would include the medical schools and the nursing schools and the rehabilitation schools, because they also have a side of offering care and of training those who offer care. So when you put it like that, yes, maybe. I mean, we do train. We train more the side of the people who go into public health, who think about policies at the population level rather than healthcare, which is more at the individual level.
So you are a university professor?
Associate, yes.
Associate. And how many years are you teaching students now?
11.
11. And what is exactly that you teach them?
I teach mostly at the Master of Public Health, which we have here at CUT. And it's actually one of the only programs in English. So we've always had a variety of students from many countries, including Europe and Africa. And they do bring a different perspective. And they do enrich the discussion and the classroom. So I usually teach...
When you introduce more diversity in the gene pool, gets more outcome done.
Definitely the gene pool. I think the gene pool in Cyprus is changing because younger people are taller. So I think we're changing the gene pool. Diversity is good. I mean, evolution...
proves that.
Yeah, thrives on diversity. So I teach introduction to epidemiology, applied methods in epidemiology, global health, research ethics in public health.
Oh, research ethics.
Yes. And a little bit of genetics, undergrad.
And which one is your favorite subject, generally, that you're passionate about in the whole stuff that you're doing? Not only from the, can be not from the stuff that you teach.
Yeah. I think the application, the study design, when you design a study from beginning to end, and you have to look at all the components and decide how you're going to measure A and how you're going to measure B and what else you need to measure and how this will is needed for your hypothesis, and when you have an exciting hypothesis. But also find ethics to be a very fascinating topic. I think I'm going back to my philosophy roots. I would say those two, study design and ethics.
And how do you study for you to learn and keep up to the current data? Do you search online? Do you watch podcasts? Do you speak with your colleagues? Do you read scientific papers? Do you meditate?
A lot of the things you mentioned. So talking to colleagues is always a good source for discovering new things, especially when you're talking to colleagues from other disciplines. Because the best ideas come when you mix things, when it's interdisciplinary.
Drop the mic.
So carpooling helps. When we drive here with colleagues from other departments in the university and we're discussing ideas, we almost always find something that we could work on together. So I find that is extremely interesting. I mean, I've been introduced to new concepts from colleagues which have turned out into research ideas. Going to conferences helps because you're there for 2 or 3 days with colleagues and with nothing to do but to talk.
And eat food.
And eat, yes.
The best two things in life.
Yeah. And of course, reading papers. But I would have to say, because time is limited, talking.
Now you can put the scientific. It's my only opportunity to understand scientific papers. I can put ChatGPT to summarize and make it explain for a 5-year-old the paper. And I can finally understand scientific papers.
Great. I mean, we should be, and that's one of the reasons why I agreed to this podcast. We should communicate our science more. And that's important because, especially in public health or in other sciences as well.
This is her first official public appearance, ladies and gentlemen. We're very lucky to have her.
Except in conferences. We're asking people to do things, whether it is to exercise more, to be more physically active, or eat better, or go into lockdown, or wear a mask, or wash their hands. And when we're asking people to do stuff they don't understand the reason behind to, they're less likely to do it. So unless we communicate science appropriately, we're not helping ourselves in the end.
And also, not only for people to do the stuff, when you communicate science, like you made more people excited about science to understand, and you give diversity of ideas, different perspective in the table, and like you advance the conversation, and that can generate a lot of outcome.
Exactly. And what you described is essentially participatory research, a concept which I was introduced to by colleague Dr. Nikos Mitleton, which essentially means that, especially in when you're researching social factors or behavioral factors, it's important to take everyone's perspective, especially the ones who you expect to act. So if I'm doing, if I'm saying people, you need to eat one more fruit a day because we know it reduces your risk for A, B, C, D, okay? If I say it this way, will people A, understand, B, be motivated, and C, do it? So I need to sit around in a table with the people who are my target, right? My target audience, and ask them, how would you like me to give you this information? What would you like to know more? What are your take on this? And just listen to them.
Or make 10 different times, exactly. And then you see and measure well. But
and it's a concept of the personalized communication medicine, which I'm sure you know more about being in social media, but it's a concept
I don't know.
It's a concept of the message being personalized to the target audience so that it has a better reach.
Interesting.
So you do a personalized podcast for different ages versus another blog or whatever for younger ages.
Yes. So how do you communicate to people and from your experience, and make people exercise more, and like because every disease has like their kind of formula how to prevent it, kind of, and everyone is different. And everyone, if you tell them to do, for example, intermediate fast, might damage them because they are different biochemistry or whatever. But so how do you go about these topics? And do you give advice generally on how people this is kind of one aspect of healthcare, to give advice to people how to live their lives?
Excellent point. Would public health advice be healthcare, be considered healthcare? That's an excellent point, which I need to think more about. If giving advice and following advice was easy, I would be healthier because I would follow my own advice. So it's difficult with the majority of the non-communicable diseases we talked about share common risk factors. So obesity, smoking, harmful use of alcohol, an unhealthy diet, lack of physical activity. Those are the 5 main risk factors that increase the risk for almost all non-communicable diseases, right? So let's just eat healthy, be physically active, quit smoking, only drink alcohol in moderation, and what was the fifth? I can't remember. It should be easy, right?
It's very easy for me, at least.
Well, it's very difficult for me. And through time, we've tended to focus more on the individual. So the advice was lose weight, be more physically active, eat better, quit smoking.
And we became these stupid motivational speakers that they are not effective.
If they are effective, fine. But, but essentially, we're living in an environment that is making it easier for us to do the bad thing, the wrong choice, rather than the right choice. So I can't tell people to be more physically active, but at the same time, I have to drive everywhere. So I think now we need to shift the focus from the individual to the place.
Meaning,
the place where you live, the environment where you live, and that includes both the built environment, so parks, cyclist pathways, all that, but also the working environment and the social environment. They all have to make it easier for you to make the right choice. Where the things are in a supermarket.
Interesting. Wow, so we need to input regulations because then we are manipulating society to do the right thing without them knowing.
I would take away the manipulation word.
Of course, we're manipulating society to exercise.
We're making it easier for the
we
individual.
remove friction. Like we have like here, it's easier to exercise because you have the sea, you have all this stuff. I will put some B-roll for people to exercise there, to do some pull-ups, some push-ups in the parks and stuff, or maybe reducing the fee of gyms can be another way for people to barrier to entry, or like have more marathons here, like sponsor marathons for people to and it's like you slowly build that. Yeah, that's interesting. With the regulation, you can do a lot of stuff.
And that's the concept of people and place. So it's not just about people, it's also about place. And one affects the other. Because if you like to, for example, run, you may live in a neighborhood that has a gym nearby. So you've also chosen your place, but you're also affecting the place you live. You may
but nobody kind of chooses the place that they are, because they are, this is the money that I have, this is what I can afford, so this is the only option that they have, or I'm staying to my father's place. So actually this is a great idea. I'm very excited by it, and this is the power when you have as regulators and when you're the president of the country and all this all this stuff that can affect big time the society.
It takes a lot of money and effort, but if you have, it's the idea of the socio-ecological model. So if you really want to have change that is sustainable, you have to target several levels. So you target the individual, yes, you make sure that they know what they need to do, but you also target the family, the community, the country, and the policy, the government. So you need to have changes in all of those areas to be able to have a sustainable and long-term change.
And you can do that not only with the public sector, to the health sector, you can do that with all the sectors. I consider one of the gems that young people have in Nicosia is the university library of the university. And it became like a hub. So old people go to work there, young people, like even students from high school, they like it because it's cool to go there and take a story or something. So it became, yes, I think. So it became this thing. And when you encourage this, to have more of those things or different like you make an environment for learning, for working, for productivity,
exactly,
for relationship. So I never thought about that. I was like, okay, let's make a video to teach people how to do this, or let's make so people can see it. But like when you influence the stuff around them, it's like maybe it's stronger than just to tell them do that. Is that because they will not have a choice but to do that.
Not that we'll not have a choice. I don't like the lack of choice, but it will be an easier choice. So not everyone has your level of self-discipline. I have none. So unless it's easy for me to be more physically active, to eat healthier, to do all those things, I'm probably not going to do it.
Okay, we agree, but you don't like the word manipulation. It's okay.
That raises ethical dilemma and lack of choice. It has to be the easy choice.
So you, as I understood, you really like these philosophical topics about when was you started falling in love with this stuff? It was when you were younger, when you... And also maybe touch a bit on what's your, like, you grew up in Cyprus, you went to study, like a bit of your life.
Well, I grew up in Nicosia, in Cyprus. I went to study in Greece, biology. Then I came back to Cyprus and I did my PhD in molecular biology at the University of Cyprus, but it took me towards epidemiology. So I studied from genetics, but to be honest...
Did you like studying this stuff, or it was like...
I love biology because it explains how organisms work. And I like genetics, but I didn't like the fact that you were focusing on a single pathway with this gene and that protein. I didn't like the micro level of it. I prefer the bigger picture. So epidemiology was a very good fit for me because epidemiology looks at the bigger picture. It looks at the population.
Interest.
Not even the individual, the population. So after my my PhD, which touched on epidemiology of cardiovascular disease, I went to London, to the London School of Hygiene and Tropical Medicine and did a master's in epidemiology.
And that's when you fall in love with philosophy.
No, that's when I really understood the concepts of epidemiology and I realized I really liked them. I think I always had a bit of a philosophical liking, but when I went into the more sciences, more concrete sciences, I sort of left it on the back burner. But in the past few years, when I've also moved my research more from the genetics and the biochemical risk factors towards the behavioral and the social, it rekindled the fact that I like abstract things more. And I've studied from bioethics, so I also sit at the Cyprus National Bioethics Committee. And from there, I, when you start reading ethics, you fall into philosophy. It's sort of not necessary, but it's, it's kind of where it leads you. So I now have a part of my research that has to do with ethics.
What exactly?
Well, one of my PhD students is working on ethical issues on digital, on the use of digital technology for healthcare, both from the side of the provider and the patient.
Meaning, what exactly?
Issues that have to do with data ownership, with informed consent, with well, we still haven't finished the topic, with ease of use, with accessibility, with equity or quality. So, for example, you have an application, but can everyone use it?
Mm-hmm.
So if not everyone can use it, then one benefits more and the other is liking out of something because you now have an application and you don't have to talk to them. So issues like that. And
such a hard thing to talk about ethics. It's very hard. Like how it's like also is difficult, dark thing because you decide, okay, this guy you should die and the other guy should live, and or we give people to suffer more on the we lock them in their house to have more mental problems to just solve the other problem that we think is more difficult. It's all our perception of how we think things, and we might have big effects on the society with the wrong. It's like paving the road to hell with good intentions. Sometimes can lead this.
I won't go there. No, but what's interesting in ethics, and ethics is a formal discipline that discusses morals. As a society, we all have our morals. You have morals as an individual. You know what is good or bad for you. You're faced with decisions on an everyday basis. Should I do this or that? And you make moral decisions all the time. So what ethics does as a formal discipline is that it provides the vocabulary, the words that we all agree on, and we can use that vocabulary and that terminology to discuss issues and dilemmas, put it all out in the open. So it provides transparency on the decision making, because then you can say, yes, I've decided to do that, but I considered this argument. I've talked to all the stakeholders, all the people who would be affected by that decision, and we all agreed that our shared decision is this, and therefore we're all supporting this. And one of the things, because you alluded to the pandemic again, one of the things that perhaps we didn't do as well was the transparency in the way that decisions were made. We made the right decision, yes, right? But the people didn't know how we came to that decision.
We're not sure if we made the right decision.
At different points.
It depends on what, on what the outcome. We made the right decision maybe with the outcome that we said together. So.
Right. Yes, right. You have to agree on something. But I think what lacked, and that also has to do with the communication of science and the having a population that is science literate, so they can understand very difficult concepts, I'll be honest, is that we skip the middle part of showing our thought process and communicating that thought process with the population.
And we were just corrupt because like Anthony Fauci in the United States was saying different things. They put him as the spokesperson. Pharma companies was associated with him. So it's like, it's so many stuff that is not that so innocent. Yeah, we need just to communicate a bit more better.
Look, I don't know what happened in other countries, but I do know that there's a lot of corruption in pharma at any given time point. I don't think this was one of those cases.
You don't think?
I don't think so, because it was such a state of emergency.
You don't think the pharma companies took advantage of the whole situation to make trillions of dollars?
Well, they are companies, but they provided something that we needed immediately. So they gave something that we needed, and they need to make a profit for it, for developing it, right? I will be the last to support pharmaceutical companies, but they are providing a service, right?
So, continue. You think that the moral continue about the moral on the societal level on.
Okay, so again, when we said that life is the most valuable thing, and we all agree on that, and we will try and safeguard that first and foremost, and then everything else, and we base decisions on that. Perhaps the thing that we didn't do as well as we could as a scientific community was communicate to the people our thought process and explain that this is a situation that is evolving as we speak. We don't know everything. Things change, data change day by day. And if I tell you something today and something different tomorrow, it's not because I'm changing my mind because I'm corrupt or whatever. It's because the data has changed and I have to follow the evidence.
And definitely in Cyprus, I think we did a very bad job of explaining the stuff. Because like this, even to the TV, that people went in the TV to speak about they were like mentioning some terminologies, difficult, people didn't really understand what is the vaccine, what is the effect that it will help. Like, and it's like it as a byproduct, it used like, it was a conflict in the society, like the people that they put vaccines and the people that they don't put vaccines, and it created this. It created big problems in societal problem because of the lack of explaining what you were saying.
But the conflict that arose in most countries was perhaps a byproduct of not explaining it transparently our thought process.
So what do you
And of course, sorry to interrupt, and of course, the majority of the society agreed with things. It's just that the people who are usually against something are the ones who shout louder. So they tend to be heard more. But the majority of people were okay with that situation. And if we had explained our thought process more transparently, I think more of them would be okay with that and would agree and would support.
What does that mean? Explain our thoughts more transparent. Like you going outside and shouting with a thing. Like what do you mean by that?
No, I mean, you explain that this is the data.
Where do you
This is-
explain the TV? You make a YouTube videos. How do you explain to your students that how do you put the president of the country to speak with the people? Like, how do you communicate?
Well, I'm definitely not a communications expert, so perhaps you could have more to say on the topic. I think it depends on the country structure. I mean, New Zealand had a president, as the focal point. So she came on TV every day or every week and explained things. And that was what worked best for that society. What works better for another society would be perhaps the head of the ministry,
Yes.
or
And
it depends on the society.
Yes, how
Exactly.
they perceive things, and like because to Cyprus, if you come and lecture them every day, will say, go away. Like you need to approach every person and reverse engineer to their
Personalized communication messages again.
personalized communication. So what did you learn by teaching these hard things to your students? Like about teaching, tell me some stuff that you learn along the way from teacher. Describe me also the experience. Is it fulfilling? Like,
Well, because I was lucky enough to have a varied audience, I do learn a lot.
because of a lot of topics that you teach.
And the students come from different disciplines.
Variety,
So
yes.
epidemiology is mostly a postgraduate science. So you can come to it and do a master's in public health or epidemiology from a lot of disciplines. You could come from biology, from chemistry, from pharmacy, from medicine, from nursing, from sociology, from great different backgrounds. And they each bring a perspective. So whenever we're discussing things, I'm always learning new things from my students, which is why I'm still finding very interesting. One of the other things I learned is that unless you know something very well, you can't explain it well. So hopefully you understood at least a few things. Otherwise, I didn't know them very well.
I understood a lot of things.
And if you can't explain something to someone within 10 minutes, don't explain it at all. I mean, don't say it at all. If you can't say your thoughts in 10 minutes, then you wouldn't be able to tell them in an hour.
So it's a process that you love, the teaching.
I liked it more than I thought I would, because I'm not very natural with people. But I do like it more than I thought I would 11 years ago, exactly because I like the subjects I teach, and exactly because it's such a varied audience, and because I do learn things every day, and I like learning things. Otherwise, I wouldn't be an academic.
So you learn a lot of things by talking with your students, and like maybe they know about that thing that came out, or they also know about the technology a bit better than you because they are younger and they're more immersed in the technologies and stuff. Yes, and it needs an open mind to understand that you can learn stuff from your students because a lot of teachers they close that window. Okay, I'm the authority here. There is nothing for me to learn from them.
No, I do have some education from the UK and the US, and it's the reverse concept, is that you can learn from your students. So I'm more into that. Like I said, I like learning. And you also need to be able to put yourself in the other person's shoes. So show empathy, and not just for teaching, for everything. I find especially when we're discussing ethical dilemmas, it's important to put yourself to understand where that other person is coming from. Because if you go in with an argument and they come in with an argument and you're just stating that argument, but not really listening or understanding what the other person is saying, you will never agree on anything.
Yes. And it will not be useful for both of the people in the argument if you cannot understand and empathize. One thing that I am thinking all this time of this podcast is I want you to explain me about CRISPR editing, because I don't really know a lot of things about it. I heard that it's a big innovation in the new health stuff. So if you can take a moment to explain me, also explain me what is the future, not what is the future, what it is and what can become.
Okay. Not entirely my area of expertise. So very simplistically speaking, two independent researchers, Emmanuel Charpentier in France and Jennifer Doudna in the US, both discovered this system, which essentially exists in cells. Don't remember which type of cells, of viruses, or don't quote me on that. But it's a molecular system that essentially it's like you have a sequence of letters and you can direct it to the specific letter you want. It will cut that letter out and the machinery of the cell will fill it in with another one. So what you do is, because mutations are just changes of DNA, the DNA is just letters. Imagine it like letters, continuous letters. And those letters make up genes, which are just pieces of letters that tell the cell, build this molecule, build collagen, build something else. And the cell does that. And if there is a change in that letter, the cell won't be able to produce that molecule correctly. So what CRISPR-Cas9 does is that you can tell it to focus on that specific change that is making the gene not work, cut it, and replace it with the right one. So you can fix the gene.
That means that when you detect that your child will have more diabetes, let's say, you can see it and edit the genome for your child to not develop diabetes.
Well, it only works on single gene diseases because you can make very specific changes. So you can work on one gene, you can correct that. But if we're talking about many, many genes and you don't know whether or not those changes that you will do in so many genes, what kind of effect they will have. So it's currently I think it can only be developed for single gene diseases. So if you have a disease that runs in your family, like FH, I'll come back to my original example of hypercholesterolemia, and you know what the change is. You know because it runs in your family. In your child, for example, you can change back to the letter that was supposed to be so that the gene works. And by doing that, you take away the disease, essentially.
Wow.
I think what the biggest ethical issues around CRISPR-9 are is that you can do that with the cells of your body. So you fix it for you, which is fine, right? You would treat any disease you have. I think that's commonly acceptable. But if you do it in your reproductive cells, you can pass on that correction, that change you did to your children. And that's where the things become grayer. Because if you can do it for diseases, right? But then people might decide to do it for other things as well that are controlled by single genes.
Like being cleverer, or like being more blonde, or like being have more easier for you to develop a more shaped body. So it becomes...
Well, all of those things are controlled by many genes, so it would be more difficult. But yes, the basic concern is that if you can change things and those changes can pass on to your offspring.
Selective breeding.
Yes. But like I said, it's for single genes only.
So we're going, if this becomes for multiple.
I don't think it would become for multiple, for complex diseases or traits,
Why?
because first of all, it becomes much more complicated to change all of those things specifically. And second of all,
The AI will tell you,
AI
cut
will
this
tell you.
part, cut this part, cut this part.
And second of all, if you change so many things, I don't think we're knowing definitely what will happen in the end, because maybe the thing you changed in gene 1 interacts with something else in gene 3 that you didn't change, and now that
Because you said
interaction
everything
doesn't.
is a combination of everything and it's chaotic thing. If you
It's
put
not
one
chaotic, but we
up,
don't know exactly how everything interacts with everything else.
yeah, it's chaotic because the
Yeah.
chaos theory is like if you raise something that might change the whole outcome of the
Yeah.
of the.
So it's very exciting. There are genetic therapies based on that are being developed right now. But again, very exciting. It has a lot of potential for single gene diseases, but we then need to figure out issues of equity, of access of equity, because those, gene treatments are extremely expensive. They're not offered globally. So again, you have an issue of access. So if you're poor or you live somewhere else and you don't have access to it, but the therapy exists, shouldn't you have access to it? So there's a lot of
And
issues
it
there.
comes back to what we were saying before, because between the inequality of,
Yeah.
of access to stuff. Did you have problems or being a woman in your industry? Do you think it's more difficult to become professor, whatever, associate professor, when you are a woman, and maybe in this country that we are?
I do think that it's more difficult for women to pursue more advanced positions, just because we're expected to do many more things. So if you decide to have a family, you have to do it at a specific age range, right? So at that specific age range, you can't be fully committed to your job like a man could. After that, you still have other societal burdens. So I think it is definitely more difficult.
Societal burden.
Societal burden.
Is
So we
good
don't-
word for racism.
so we don't live in a truly equal society for men and women. I'll say that. There's more things we could do, like more flexible maternity leaves and other things. I can't say I've found it very difficult. I can't say that.
Sometimes, though, did you find, oh, because I'm a woman, this door is closed, or because I'm a woman that I didn't get that opportunity? They are treating me, don't believe in me. Because did you find this stuff?
I would say that I was lucky enough not to have doors closed because I'm a woman. But I have found that sometimes there is a more gentle bias. So
Can
if
you
you're in
give
it,
me an example?
especially in academia, I think older white men are considered the norm. So I think a woman has to prove herself more, not just in academia and everywhere, to be considered an equal. I would argue that I've been very lucky, but I can think of maybe a couple of instances throughout my life of maybe a subtle bias of like saying something and then having a man reiterate that, and then it was considered more important because they said it. But I don't think I've had many difficulties as a woman. But again, I have been one of the very lucky ones because I can see how gender inequity can be an issue. And in fact, gender issues are something that we haven't placed a lot of importance with regards to chronic disease. And I'll speak about heart disease. Gender is a risk factor for heart disease. So men have a higher risk for heart disease, right? But it doesn't mean that women don't have a risk. But as a woman, both in the way that we view ourselves, lower risk, and the way that a a doctor might view them, for example, as lower risk, could result in them being having different treatments or different treatment goals. And again, I'll speak for something that I know. In familial hypercholesterolemia, there are data that show that women with FH usually get a lower dosage of drugs.
FH meaning?
Familial hypercholesterolemia. So if you have that, you need to take drugs that lower your cholesterol, right? Statins. And there are data that show that women tend to be prescribed lower dosage because they're viewed as less risky patients and therefore are less likely to lower their cholesterol to where it should be compared to men.
So we find that inequality in all aspects, in drug treatment, in drug...
I think if you look, you will find it. It might be from more subtle to more pronounced, but we do have some work to do. But it's good that we're starting to acknowledge it and identify it and discussing it, because that's the first step to addressing it.
Yeah, 50 years ago, some women were not able to be professors.
Well, they did, but they have to be much, much better than any man to get there. And they would have to make personal sacrifices with regards to their family life.
Which is something that a lot of women, when I bring this conversation up, they're saying that all the time about the maternity leaves, so for me, I'm like, oh, again, they're bringing this up. And I'm like, I don't really understand it because I'm not in that position. So that's why it is a problem, and it's some of maybe the woman's hands to change that, because as men...
And daughters.
What?
And daughters. And any genders.
Yes, because we don't understand the problems here. That these, like for me, obviously I want to have a family, and I'm never consider I will give up your work
job
for a family. But like when you are a woman, it's like it's an inevitable thing that you have to do.
You may not quit your job, but you may work fewer hours because you have many more things to do in your family life. You can't work late all the time. You can't.
Yes.
But public health, that actually has a public health component, because when you take the mothers away from taking care of their children, you're depriving the children of both emotional bonds and care that will lead to them having better health in the future and being better adjusted adults. And there's a lot of evidence to show the importance of the first 1,000 days of a child's life from conception up until age 2. And that's where they really need one dedicated carer, and that's usually the mother. But if the mother has to go back to work for months and they don't have that, either with a grandparent or another carer, that has an impact on the future adults. A very difficult podcast.
Yeah, difficult topic, because when I think there is this is kind of a limit, because for you to become an exceptional individual, you need to work harder than everyone else. Like you need to go through through a lot more difficult stuff. And it's like when you have the choice that you want to have a family or pursue the career, then you are like just closing the door to become that exception, because you cannot just to give up stuff when it's like the momentum will leave in your career, the stuff, and especially when you are building a business, it's like you're not just having a job to steal, or it becomes a lot. So maybe that is like a limit threshold, like it's like a bottleneck for women to thrive more in general.
You've said it very beautifully. And when you asked if I had doors closed, no, I didn't have doors closed, but I may have closed a few doors
to
by
pursue
deciding.
family.
Exactly.
Which now you have 2 kids that you don't allow them to use phones.
Yes.
So I wanted to ask you about the pharma opinion. You said you have very negative feelings about them.
No, I didn't say I have very negative feelings about them. I said they're a business and they operate like a business, like most business do.
So do you like this word? Like, do you agree with the word, like prescribe drugs for everything? Like, oh, you have like, take this drug, like,
Well, it depends if you need it. If you need it, a drug can save your life, right? You just need to be careful that you do need that drug. But we're now thinking more in the concept of, when we're thinking treatment, so a disease is already there, or primary prevention of disease, drugs are great, okay? But all drugs have side effects, whether very small or very big. I mean, if you read the leaflet on your Panadol, you probably never take Panadol, right? But you need that when you're treating a disease. Now we've moved 2 steps before, the concept of preventing disease and preventing the risk factors for disease. So prevent a person becoming diabetic by preventing them, by helping them be physically active, eating better, all those stuff. And for that, you don't need drugs necessarily. For that, you need a lifestyle, right? And we're now discussing the concept of lifestyle medicine. Meaning that you sort of prescribe a lifestyle. So if you see a patient that is socially isolated, for example, what they need is to be more socially engaged. So if you can sort of prescribe that, if you can ask them to join a community center and they do that, or you introduce them to a network of people of their age or hobbies or whatever, that is helping a risk factor for disease. It's preventing disease, but it's not by drugs, it's by lifestyle.
And tell them to go to the gym and tell them to...
And again, it's easy for them to go to the gym and it's easy for them to, yeah.
So you're saying that we need to put, to solve the diseases is not only drugs. There is multiple ways preventing the thing, and we need to put more effort into all these things, not just to give them drugs.
Yes. Wouldn't you agree? Not everything can be solved by a pill, but a lot of things need a pill.
Me, I was kind of skeptical all my life about pills, so I would never drink pills even if I bad or whatever. So I convinced myself, that I'm never sick, and it's been like years. Since.
You're also young and healthy and fit, so that might play a part.
But the thing that I was trying to say is that then I was like, oh my God, like there is some studies that they say, okay, just having food in your stomach changes your psychology, your actions. So of course a drug can change your biochemistry and can do stuff in your body. So I didn't understand how drugs work. But when I understood how drugs work, I was like, oh, that's very interesting. I don't think a lot of people understand how drugs work.
They don't necessarily need to, because that is when you reach to the point where you need pharmaceutical treatment, that is prescribed by someone who, medical professional, who should explain how that works. But and it should be a joint decision about treatment. But if you reach to the point where you need drugs, I would take the drugs, definitely. As long as I was fully aware of why I'm doing this, what are the potential side effects if I do it, and what are the potential effects if I don't do it. And I make an informed decision. And again, when we're talking about informed consent and informed decisions about a person's healthcare should be
asking 2 doctors about what do you think should I. They can 2 opinions, because you need to get an informed decision, because some people can be naturally biased or they have an opinion a bit more extreme. So asking and researching about, okay, I have this treatment, chemotherapy. So should I just take it blindly? What are some alternatives? What do you think?
But you are discussing that with your doctor, and your doctor should be able to tell you.
The doctor is not the authority in the world, the whole world. So
Who is the authority?
maybe maybe a different doctor will tell you it's in a different stage. Maybe we can treat it differently. Maybe we can do a search. So I'm saying that taking an educated decision, not dependent on one source, is always a good idea. That's why always a debate helps. Multiple ideas in the table help you to have a better decision.
Okay. The best, usually there's a healthcare team. So for specific conditions, there will be a team of different expertise that you would consult. It doesn't always happen, but I will respond in the sense that, in the same way that a colleague of mine from Israel said, that by default you go to 2 doctors. One is nothing. You have to go to 2 at least. But again, you have a point.
Agree?
No, you have a point that, especially for more complex conditions such as cancer treatment, you said there should be a healthcare team that includes a lot of disciplines, and they sit with you and they explain what are the choices, and you together decide which is the best choice for you.
Do you think if I ask a doctor here in Cyprus, tell me how do I treat a specific disease, and I ask in 5 different countries in the world, I will get the same answer?
You should get the same answer because there are international guidelines on how you treat specific symptoms and specific conditions. Okay, I know a little bit of the evidence, so I will make perhaps a biased decision if I base it only on what I know and what I think. So with regards to how you treat specific conditions, there are groups of experts that gather together, review all of the available evidence on a given situation, on a given drug, on a given condition, and they together decide what is the best course. And those guidelines, those protocols, are usually followed by the clinicians of that discipline. And you would have, let's say, the European Society of Cardiology guidelines on how to treat disease, and all the cardiologists in Europe would follow that. And you would have the American Heart Association guidelines, and they're usually very similar because they review the same evidence, and you would follow that. So technically, yes, you should get the same answer if you ask 5 different doctors in Europe, as long as they follow the same international European guidelines.
I want to ask you a question that is a bit, I stole it from one person that I look up to, a podcaster, Lex Friedman. What's the meaning of life? And this is a closing question, so you can tell us whatever you want with what's the meaning of life.
If I could answer that question, I would not be here.
Where you were going to be.
I think that is a question that has driven most of humanity to discover things. So I wouldn't have an answer to that. But there are many ways to look at it. You can look at it, what is the meaning of human life? What is the meaning of life altogether? Is there a meaning to, are we that important? So there is no meaning to human life? I mean, we're just a speck in the universe. So there is no meaning, just live and let live. Or
live
do we have...
let live.
Not as simple, but yes, I think that's a huge topic that I wouldn't be able to discuss.
What do you want to leave behind in this world? You personally.
I did think about it a few years ago. We tend to focus more in academia and research, in publications and rankings, because that's how we're evaluated as well. And I think it would be more important if I improved, regardless of publications or all that, if I could have a very small impact in improving the life of the population in Cyprus, where I live and where it's my obligation to do it. I think I would be very happy if I could accomplish that.
A small impact in what way? Because impact is easy to have. but in what direction, in what way?
Well, in my area, so heart disease. So if I could have a small impact in changing, let's say, some guidelines or a policy that will have a benefit on the population, I think that would be enough for me.
And with that being said, thank you so much for your time.
You're welcome. Thank you.
And here it is, her first public podcast. Woohoo! Bye bye, guys. Thank you for watching.